Firstly, I think that you guys have done an amazing job with the online. I've been keeping up with the online lectures. Obviously, we're all missing sitting and having a sasha tort and relaxing and some coffee and interacting with people. So I think if I just run through a couple of the posters, the first poster is actually based on an MMed by one of my registrars or residents, Alexandria, and it's important. It looks at what we did was we looked at our patients with HER2-positive breast cancer, which I think is super relevant in terms of the lectures we've had, and looked at the ones undergoing the early stage neoadjuvant chemotherapy with Herceptin. And the relevance is that our data basically mimics what everyone's seeing throughout the world, that you are seeing the ER/PR negatives, HER2 positives, and we're looking not at dual therapy, but just with Herceptin. Who has a PCR and who doesn't have a PCR. And obviously we see with the triple positives less complete pathological response than the ER-positive PR negatives or ER/PR negatives and high KIs. And I think it's hugely relevant in our South African scenario because our patients don't have access in the government setting to Herceptin in the neoadjuvant. So it's an early stage disease. They prefer us to operate on the patient first and then give Herceptin afterwards. And when you look at the data, we really want access to our state patients to have Herceptin or one of the biosimilars in a neoadjuvant setting. So I think it's a super relevant poster. Obviously in my private unit, which is where the data comes from, we basically treat as you do through the rest of the world. And what we are looking forward to is utilizing more dual therapy in the neoadjuvant setting. So hopefully in a year or two, we can present that PCR data, which I think would be excellent. I've got a good couple of patients currently who are going to have dual therapy and with their neoadjuvant treatment. So that was the first one. Professor Rappaport is really the person to speak to in this country around triple-negative breast cancers, and I'm sure you're going to interview him. And together we put together a really nice poster looking at, again, PCR in our triple-negative breast cancer patients. And we've been keeping in touch with what's happening in the rest of the world. And it would be nice, basically, our primary oncology treatment would be TAC with Neulastine and with close ultrasound follow-up every 2 cycles of chemotherapy. And what we see is that, again, the patients that do well do really well. What we've got happening at the moment with our pathologists is we are upfront looking at the core biopsies and documenting what the TILs are, tumor-infiltrating lymphocytes, and the patients with high levels of those obviously seem to do better. And it would be nice, instead of the ones that don't respond so well, moving them on to a platinum-based, is to look at other treatments, PD-L1s, etc. So I think that's very, very important.